Hi everyone, this is Tim, your lecture instructor for the Paramedic to RN Transition Program. And today's PowerPoint is going to be on HIV and AIDS. This is also chapter 37 in your book. I will pre-warn you that I think that the boxes in this chapter are very informative, so definitely look through all those boxes. I like them because they're very quick. They're easy to read. They're listing things as far as whether they're symptoms or interventions or rationales, things like that and stuff. So definitely pay attention to those as you read through the chapter. I do not expect you to know the meds because there's a lot of them and you don't have to actually memorize them, but just understand kind of a general consensus as far as what they do, side effects, just odds and ends of stuff. Um, yeah, so I think that's pretty much about it. Just like I said, just go through the boxes, along with your reading. But I think the boxes, I think they're just very helpful. So kind of pay attention to those as you read. All right, so for HIV and AIDS, so HIV is the human immunodeficiency virus, and AIDS is the acquired immunodeficiency syndrome. The way I think about it is that HIV is the disease itself, and based on your labs and your CD4 count, um, it goes from HIV to AIDS based on you being immunosuppressed. This is a chronic disease, and due to ART, which is the actual treatment for HIV infection, this has turned this disease from being deadly to now being a chronic disease that people can actually live with. There are 3 decades for this disease. And the reason why I say that there's 3 decades is because the first decade of the HIV disease itself, it was there. They didn't really know exactly, whether it was caused, medications that will actually work, how is, if it was curable, how to actually even test for it. So late 80s, early 90s, researchers really scrambled to do as much research as they possibly could to actually figure out how to either stop it, fix it, or prevent it. They did come up with a lot of blood work. They came up with a lot of therapies as far as for medications to find out if it was able to suppress the disease itself. And then that led to the second decade, which then developed HAART, which is heart, which actually became more of a better treatment. But again, it then turned into the third decade, which then became better meds, and people were able to, again, be able to live longer and stuff. The third decade also came up with the HIV antibody test, so this was a little bit more exact and testing for antibodies itself. They now actually have the rapid HIV testing. Basically, they take they prick your finger, take a little bit of blood, they drop it on a slide or some sort of card. It sits there for about 20 minutes, and then they actually drop some developer on it. And if it comes up positive, they will literally tell you that it's either positive or negative. If it is positive, the test itself is so accurate, it will actually tell you where you are in the progression of HIV itself. So just because you come up positive doesn't mean you just came up positive last week. It could mean that you've actually had it for a while. You're just now having the symptoms, or something is leading you to believe that you need to be tested, or your doctor may actually say, your symptoms sound more like this, and let's test you for just different things, and they happen to throw an HIV test in there. So but again, things have come a long way in the last 40, 50, 60 years of this disease as far as testing, medications, and again, we really start to keep telling, still informing our patients and educating them, so that way, maybe one day this will become eradicated. So goals for HIV and AIDS. So the goal is to actually reduce the number of those infected, increase access to care. There's still millions of people in the world that just still don't have the access to the medication to be able to help control their HIV. And then reducing HIV-related disparities. So again, millions of people are in the world are dying because of the fact that they don't actually have the care to be able to live healthier lives through medication. HIV transmission, it's through bodily fluids. It could be from mother to child in utero. Breastfeeding, HIV is not transmitted through casual contact. It could also be transmitted through blood transfusions, but the possibility of infection is virtually limited. As testing has gotten better and as because of HIV people becoming healthier, living longer, and not that they ever, donated before, but again, the transmission of blood products is again next to nothing based on us being able to test it and test it better. Risk factors are sharing infected injectable equipment, having sexual relationships with someone who is actually infected, infants born to mothers who are HIV infected, breastfeeding, people who receive organ transplants, and HIV infected blood. So again, especially between 1978 and 1985, this was the case, but now it's 2017, and they actually have a better handle on testing and transfusions. Gerontological considerations. I did my bachelor capstone on HIV in older adults, which was very interesting. It was a field that researchers were actually starting to look into. These are adults that are over the age of 60, and the reason why they're interesting is because of the fact that the baby boomers did not live their entire life with this disease. This was either something that they had heard about, read about, maybe understand a little bit about, but because of the fact that they're older and they're with others who are older, they tend to not believe that this is a disease that will actually affect them or their community. So for considerations for them, they are sexually active. They do not use condoms. That could either be a generational thing or they believe that they don't have to or don't like to. They don't consider themselves at risk for HIV. Things to also consider is older men with younger companions, older adults becoming HIV or becoming IV drug users, older adults who received infected blood transfusions before 1985, and the reduction in immune system as an older adult. So those who are in their 60s, 70s, and 80s, or even 90s, their immune system is not like it used to be. So it's lower. They're still healthy, but then once they actually come in contact with opportunistic diseases such as HIV, then things kind of change a little bit. So they don't have the immune system that they used to have. Until there's a vaccination, which there's not, the only prevention we have is actually using condoms, preventing women from actually becoming pregnant to pass on to their children. We also need to prevent drug users from actually sharing needles. Major cities in the country have the exchange program, so they can actually exchange their dirty needles for clean ones. Some people believe that that actually promotes drug use. My opinion, I think that they're going to use whether it's clean or not, so we might as well continue giving them clean ones. And then as far as contaminated blood, again, that based on it now being 2017, it's highly unlikely that the transfusion, but it's still there. Never say never, but it's highly unlikely that the transfusion will cause HIV. So the best thing we can actually do is prevention and education. So for your patients or those who you're trying to educate, you want to share with them the idea of standard precautions, safer sex practices, and safer behaviors. So they want to abstain from sharing sexual fluids, have those who are trying to educate reduce the number of sexual partners to one, always use latex condoms, and if allergic to latex, use a non-latex condom. Um, Share with them as far as education about not sharing drug-injected equipment and blood screening and treatment for blood products. So prevention for you guys as the nurse and the healthcare providers, you're going to use really good hand hygiene. So basically soap and water, gelling in and gelling out as you go in and out of patients' rooms. You want to make sure that you have personal protective equipment like the gloves. If there's a possibility that you come in contact with their blood. This last weekend, I had a patient whose IV came out and he was in the bathroom, and I go in the room and there's blood on the walls and on the floor and on the sink. I mean, he just whatever he touched, he just had blood everywhere. And I put gloves on when I walked in, but then you start to kind of think to yourself, okay, watch where you walk, watch where you touch, make sure you don't bump up against the walls. You just kind of are a little more cautious when you walk into someone's room as far as when there's blood everywhere. Soiled patients care equipment. Again, we run the room, we step in, we jump in, we kind of put gloves on, but don't really think too much about anything else. Like I say, again, it's just about being more cautious. Making sure you don't recap your needles, making sure you use the safety on your needles, making sure that everything goes into sharps. Pretty much things we're already doing, but it's nice to be reminded. Truvada is actually a pre-exposure prophylactic. That's why they call it PrEP. It's a medication that people can take on a daily basis to prevent them from, when they do come in contact with HIV positive people, that it lowers the risk of them actually contracting it. It's taken every day. The patient or the person who's actually going to take it has to test negative for HIV and any sexually transmitted diseases. And then every 3 months, they actually have to go back to the doctor, get a blood test, and still remain HIV negative, because that's how it works. But again, this is probably the first time that they've actually had some sort of medication that people can take that will prevent them actually from contracting it. It's a great idea. I think that the more who take it, who are able to prevent it from contracting it, eventually the disease itself will slow down as far as spreading. So for post-exposure, those of you who have never had an exposure before, the first time you get one, you're going to freak out. My advice to you is don't freak out and just wash your hands or wash whatever has been exposed. You're going to go to whoever's in charge, let them know, and then they'll get the ball rolling into what they're going to do to the patient. And the first thing they'll do is they'll do something called source testing. They will actually test the patient for HIV, hepatitis B, and hepatitis C. If that patient comes up negative, that will most likely mean that you are not exposed to that. The reason why I say this is because you're going to be tested the day that you're actually exposed. You're going to be tested a month later, 3 months, 6 months, and a year later to make sure that you're continuously negative for the entire year. And I have been exposed before as through a needle stick. The first time was through a 85-year-old Asian man, and I wasn't it was my first time, so I was worried, but in the same sense, after it had happened, I kind of wasn't worried based on his lifestyle and age. I have had a second exposure, which was from a 90-year-old man who has been bound, who is in the hospital for MRSA. I really wasn't too worried about that, but then it was also my second exposure, and I was more calm. And again, I just looked at the source, and they tested him. He came up negative. I went through all the testing, and that worked out fine. But the idea is for them to test the patient, because if they do come up positive for one of these three things, then you should be a little more worried in the sense that now you've been exposed to one of those three things through a needle. So you will call employee health. That's one who actually will do it. They actually have prophylactic medication. You have to take it for 1 month. I don't believe it's the Truvada, but I do believe that it's a stronger dose of something similar. And from what I understand, for 30 days, you have a lot of GI problems, and whether it be nausea, vomiting, diarrhea. But again, those who I know who have actually taken it, they lived and everything was fine, but for a month they didn't feel very well. Let's see here. Give consent to be tested for HIV, hepatitis B and C. I already talked about the testing for you. And there's also psychological help. I had a coworker who was an aide who was exposed to a patient, and he was actually going to be marrying one of my other coworkers who was a nurse a month later. And he freaked out because it was his first time, but he also freaked out because, he's now been exposed to it, and they were supposed to get married and start a family and all this other stuff. And he was really, he's young, and he was just really worried about it. So, but they actually have psychological help. So that way people can at least, um, either learn to deal with it or at least have some sort of support to be able to go through that with them. Here's the HIV life cycle. I do not expect you to know this information on a cellular level, but what I do want you to understand is the reverse transcriptase. From what I understand, the HIV medication and even the prophylactic medication actually is what inhibits this from being infected by the HIV virus, and it actually keeps it from replicating. So that's probably the biggest thing out of the whole thing. Stages of HIV disease. There's primary infection, HIV asymptomatic infection, there's HIV symptomatic infection, and there's AIDS. With primary infection, this is also known as HIV infection or acute HIV syndrome. This is part of the CDC category A. Symptoms are none to flu-like symptoms. The window period is lack of HIV antibiotics or lack of HIV antibodies. As I was telling you about the rapid HIV testing, that's where this comes into play. So if you are, if the test itself comes up negative, then you have nothing to worry about. If the actual test comes up positive, then they're looking for the different stages. So with this one, they have lack of antibodies, so you will have a positive, but they couldn't really tell you exactly how long it's been because you don't really have much of a buildup. Period of rapid viral replication and dissemination throughout the body. The viral set point between the balance of amount of HIV and the immune response itself. With HIV asymptomatic, CDC category A is more than 500 for a CD4 lymphocyte count. Upon reaching the viral set point, the chronic asymptomatic stages begin. So again, now you're HIV positive. It is affecting your body. You still have a high CD4 count, which is good, but you don't actually have the symptoms for HIV. The body has enough immune response to fight off disease. With symptomatic, you actually have a CD4 count of 200 to 499. So you actually still have enough viral load or enough immune response to be able to help you, but you will actually start to actually have symptoms of the HIV infection. So patients who are once treated for a Category B condition is now considered Category B symptomatic. And then once your actual viral load or your CD4 count falls below 200, now you actually have AIDS. So that's what I was telling you at the very beginning. I think of HIV as being the disease itself. And then once you actually get a CD4 count less than 200, now you're actually having full-blown AIDS. As level drops below 100, the immune system is significantly impaired. And it's impaired to the point where you actually have no immune system at all. Here's your labs and diagnostic testing. So again, we must mention the CD4, the CDA count to find out where you are. There's a quick test, which basically it's a mouth swab, and or you spit in a tube and they send it off. They actually test it and then they will send it back the results. The Western blot test also detects antibodies in HIV. I believe that is strictly just a blood test where they draw tubes, and so is the EIA. And they're at one point these were the actual standard of being sure that whether you are or you're not. Now the OraQuick and the rapid HIV tests are so accurate that they're just as good. So as far as treatments and protocols are continually evolving, so some say the earlier the better. So I have known people who are HIV positive who didn't actually take the medication until the doctor decided to put it on them based on a specific viral load or CD4 count. I've talked to other people who became positive, and as soon as they became positive, the actual doctor put them on some sort of medication. So I don't know if it's preference, I don't know if it's research, but I think when people are positive and they don't take it for a length of time, I think it's more of making sure that the physician is more worried about them actually having some sort of a built-up immunity to the medication in long term. So, but I don't know. There are antiviral agents. I don't expect you to know the actual names of them. I just want you to be familiar with that there is medication. And again, if you actually look in the book and as far as the boxes where it has all the meds, look at more of like symptoms and side effects, things like that. That's what I want you to be aware of. Management also focuses upon the treatment of specific manifestations and conditions related to the disease. So the patient must adhere to the treatment regimen. So they don't get to just take it and then stop taking it and taking it and stop taking it. They actually have to take it every day at the same time in order for it to work. They can skip a dose, but they have to go back on it. They don't get to skip a dose based on not feeling like taking it. Because what happens is that when they stop taking it or they kind of intermittently take it, then that's when their body's not consistently getting the medication they need and they start to get sick. So here's your adherence to medication. The medication itself now is 1 a day, I believe, or maybe 1 or 2 a day, but they used to have to take handfuls of pills every 4 hours, and the side effects were really horrible. They did a number on their GI system, and there was just a lot of side effects that they couldn't handle, but they wanted to live, so they keep taking it. Now it's actually much easier. Again, they either take 1 or 2 pills once or twice a day, and the side effects are much, much less. When there are side effects, medications that they're taking will affect either their heart and cause heart disease, excuse me, will actually cause diabetes. And then something I didn't actually know until I was doing more research was the fat redistribution syndrome. I do know that when you actually are assessing patients that are HIV positive, they tend to be thinner and less fat content. So they actually lose the fat in their face, arms, legs, and buttocks, and that's due to the actual medication itself. Once they lose that, it's actually redistributed into the abdomen itself. So when you look at these people or when you look at people who are HIV positive, and you think to yourself, "Wow, they look very thin and, and, and I don't know, skinny," it's because of the medication itself. But then you actually look at their belly, and to me, it's more of a distended, round abdomen as opposed to more of an obese abdomen. So, but that's where the fat's been redistributed. Drug resistance to antiviral drugs. So there are drug resistance HIV, and it just takes the right medication at the right time for your patient to be able to actually get it and be able to adhere to it and for it to actually work. So IRIS, immune reconstitution inflammatory syndrome. So it's rapid restoration of pathogen-specific immune responses. Causes deterioration of treated infection or new presentation of a subclinical infection. Typically occurs during the initial month after taking ART, and that could be microbacterial, it could be herpes, fungal, it could be fever, respiratory, abdominal infections. So basically what's happening is that your body is trying to react to the fact that you are HIV positive, and it actually causes other organ or other problems within your body itself. Usually it's respiratory, gastrointestinal, ecological, neurologic, depressive, integumentary, and gynecological. So essentially, it just really is affecting every organ or every body system in your body. Your body's trying to compensate and actually try to fix it all, and it's just not working. Medical management and treatment of opportunistic infections. Many patients are unaware of their HIV status. So some are aware of their status but not take ART due to psychosocial or economic factors. Just because we live in America and it's a first world country doesn't mean that everybody actually can afford their medications. And some who actually can afford them or not can afford them go through a denial or I can't believe that this is happening to me. Period. So you have to get them on their medications. You have to be able to figure out how you can get them to take them and take them every day at the same time, and how they can actually afford it. You have social work, or even you can actually look into different avenues to be able to get the funds for them to take it. Let's see here. Other problems could be ART, but fail to attain virological or immunological response due to adherence, pharmacokinetics, and unexplained biological factors. So there is a small percentage of people who are HIV that take their medication every single day, and for whatever reason, it doesn't always actually work. And unfortunately, for them, there's nothing else. Opportunistic infections and meds. So there's pneumocystic pneumonia, there's mycobacterial avium, there's cryptomeningitis, there's cytomegalovirus, there's herpes, and there's also candidias. So these are, opportunistic infections caused by either the medication, caused by the disease itself, or a combination of both. Other diseases and symptoms. There's antidiarrheal therapy. HIV medication will still, again, cause a lot of GI problems. You can do things to help manage the diarrhea. There's chemotherapy to help combat the Kaposi sarcoma. There's also lymphoma, antidepressant therapy. There's nutritional therapy. One thing that I thought was really interesting is if you look at the picture on the bottom right, this patient, I believe, has the Kaposi sarcoma. And because of this, and it looks very painful, I'm sure he doesn't eat a lot, or she doesn't eat a lot. So you're trying to give them education on nutritional therapy, but they're looking at going, I can't eat because this hurts too much. So you got to be able to find other avenues and kind of be logical about what you educate them on and what is expected. So just like I say, just keep that in mind. Alternatives for therapies is spiritual and psychological therapy. There's nutritional therapies. There's drug therapy that is not approved by the FDA. I've heard of people who have actually left to go to Europe or other countries to be able to get medications that have been approved over there. There's acupuncture, acupressure, there's massage therapy, and there's reflexology and yoga. Not all patients report the use of alternative medications, so you really need to ask. Again, I've mentioned this to you guys before. If you don't ask, you don't, if you don't ask the right question, you don't get the right answer. So that they're on medications, they'll tell you they're on medications, but then, you have to specifically ask them, are you on any medications for over the counter? Because while they're in the hospital, you're going to treat a lot of symptoms and you just don't want to give them something that might interact with what they're taking over the counter. As far as your assessment, you're going to assess their nutritional status. Are they getting enough food? Are they actually getting enough protein, a lot of carbs, a lot of fats? You're going to look at their skin to make sure as far as either breakdown or skin rashes. You're going to assess their respiratory status, especially for HIV positive people who immune system is really kind of going downhill. They're more likely to actually get pneumonia and respiratory infections. Neurological status, they tend to become confused or encephalopathy tends to kind of kick in. You want to check their fluid and electrolyte balance, just to make sure that they're not losing their potassium and sodium through the GI tract. Because again, if this wreaks havoc on their GI system, then between nausea, vomiting, and diarrhea, they're going to start losing their electrolytes. Also, assess their knowledge level. Do they understand that they're HIV positive? Do they understand how it's being spread? Do they understand how they can, take their medications and can they afford it? And are they taking it at the same time every day? And you really want to find out what they know and what they don't know. The patients I've come in contact with or people that I actually know that are HIV positive, it's kind of a forced learning opportunity. They contracted it, and once they got over the denial, they decided to live, and they do whatever they can to make sure that they actually take their medications. They make sure that they, eat healthy, exercise. I mean, they just do whatever they can to not allow this disease to take over their life. Main symptoms of AIDS, again, I mentioned the encephalopathy, meningitis, it affects their eyes for the retinitis, lungs, again, the pneumonia. The TB is probably more of an opportunistic secondary infection than anything else. You'll look at their skin as far as for tumors and other lesions. And then again, this is really a gastrointestinal problem. So between the esophagitis, the chronic diarrhea, and the tumors, it really does wreak havoc on their system. Let's see here. What else can I tell you? I think we covered most of the chapter. Again, I do like the little boxes. I definitely like the plan of nursing care, which is on 1017. All those interventions and rationales, I really like them because it helps train you guys in the sense of keeping on track as far as what should I do and how is this, what is my expected outcome to be. So if you have any questions, go ahead and bring them to class, and I'll talk to you later.